بسم الله الرحمن الرحيم. الحمد لله الذي علم بالقلم، علم الإنسان ما لم يعلم، والصلاة والسلام على رسولنا الأكرم، أفضل من علم وأبلغ من تكلم. Our topic today is pre-labor rupture of membrane, simplified approach, Green Top Guidelines 2019. Pre-labor rupture of membrane, or what is previously termed premature rupture of membrane. At first, what is the definition? Prelabor rupture of membrane is defined as rupture of membrane before onset of labor, regardless of the gestational age. It may be term prom when it occurs after completed 37 weeks of gestation, preterm prom when occurs between 24 and 37 weeks of gestation, pre-viable prom when it occurs between 24 weeks of gestation. Viability. Viability means the ability of the fetus to survive outside the uterus. Age of fetal viability varies according to standard of neonatal care. So, different guidelines design or suggest a different gestational age to define viability. The American College of Obstetrician and Gynecologists in USA suggests that age of fetal viability is 20 weeks of gestation. However, the WHO defined fetal viability at gestational age 22 weeks of gestation. However, the Royal College Green Top Guidelines, NICE guidelines, define the age of fetal viability as 24 weeks of gestation. Now, we need to justify some definitions. What is the prolonged rupture of membrane? Prolonged rupture of membrane means the rupture of membrane for more than 18 hours before delivery. What is the latency period? It is the period from rupture of membrane to onset of labor. It tends to decrease as the gestational age of PPROM increase. The median latency period after PPROM is 7 days. Interval period, it is the period from rupture of membrane to delivery of the fetus. Incidence. Prelabor rupture of membrane complicate 11% of deliveries, 8% of term prom, and 3% of preterm prom. Preterm prom responsible for 30% of preterm births, so it is considered the most known cause of preterm labor. Etiology. Etiology involves two main items. What is the risk factors and what is the pathophysiology? As regard risk factors, for simplification, we need to classify it into modifiable risk factors and non-modifiable risk factors. Modifiable risk factors means these factors can be controlled, and their control may be reflected by reduction of the incidence of PPROM. The modifiable risk factors may be either non-obstetrical or obstetrical. Non-obstetrical includes infection, either UTI, bacteria, vaginosis, and the infection is the major risk factors for prelabor rupture of membrane. Smoking, low body weight, substance abuse, for example, cocaine abuse, poor nutrition, low socioeconomic status. However, the obstetrical risk factors include polyhydramnios, multiple sexual partners, lack of antenatal care. Non-modifiable risk factors may be either non-obstetrical or obstetrical. Non-obstetrical, including genetics or maternal age more than 35 years. Obstetrical include previous PROM, previous preterm labor, short cervix less than 25 millimeter, multiple gestation, previous cervical surgery, or uterine anomalies. Now, what is about the pathogenesis? Membrane weakness leading to rupture of membrane. What is the cause of membrane weakness? Membrane weakness means the decreased tensile strength of the amnion due to collagen degradation. At term, it is a normal physiological process involving activation of catabolic pathway and apoptosis. Apoptosis means the programmed cell death. However, in preterm labor, This decreased tensile strength of the amnion due to collagen degradation is a pathological process due to premature activation of catabolic pathway. And this premature activation of catabolic pathway is triggered by presence of infection, the major risk factors for PPRO. What is the importance of preterm pre-labor rupture of membrane? It gains its importance from its impact on both fetus, neonate, and the mother. Fetal and neonatal complications, generally it increases the prenatal mortality and morbidity and disease involved premature birth and its related complications, for example, bronchopulmonary dysplasia, necrotizing enterocolitis, intraventricular hemorrhage, and cerebral palsy. Second, oligohydramnios. When we asked about the impact of oligohydramnios on the fetus, we should distinguish between two main items. Severe brom, it is responsible for acute insult. There is severe brom or a hydramnios leading to cord compression leading to abnormal fetal heart rate pattern, and disease may require immediate termination. Prolonged prolong involves two main items: its impact on the lung and its impact on the skeletal system. Impact on the lung, it causes fetal pulmonary hypoplasia. The main question is any brom or prolonged brom leading to pulmonary hypoplasia? No. It should occur before 27 weeks of gestation, and the latency period must be more than 7 weeks. What is about skeletal deformities? It causes arthrogryposis. Arthrogryposis means contracture of the joints of the body and usually involves the large joint, and it is stationary, not progressive, associated with muscle weakness. Or talibus equinovarus, or even amputation may be caused by what's called amniotic band. Third complication is neonatal infection, either pneumonia or septicemia, fetal death, and may occur due to infection or cord accident. Maternal complication. As any obstetric case, we should divide for simplification the complications into during pregnancy, during labor, and after labor. During pregnancy, brom equal infection, maybe chorioamnitis, malpresentation, abruptio placenta. However, during labor, it may be complicated labor, either preterm labor, increased risk or increased induction rate, and increased cesarean section rate. And the increased cesarean section rate is not simply due to failed induction, but failed induction is one of the main causes. It may be due to malpresentation, dry labor, and cord accident. What are the complications after labor? It is postpartum hemorrhage due to retained placenta and postpartum endometritis. Now, is any sudden gush of watery fluid per vagina is considered PPROM? The answer is no. There is differential diagnosis. This differential diagnosis simply include urine incontinence, vaginal discharge, either pathological or physiological, what is called leukorrhea, or some conditions called hydroxyurea gravidarum, chronic accidental hemorrhage, or accidental fluids, including semen and vaginal delivery. Now, how can you diagnose BROM? First, what is recommended according to the GTG guidelines, and second, what is non-recommended? Recommended from history. History of sudden gush of watery fluid per vagina is suggestive of prelabor rupture of membrane. When we suggest, we should confirm by sterile speculum examination. When we see amniotic fluid in the vagina, pooling of amniotic fluid in the vagina, or amniotic fluid come from the cervix during the sterile speculum examination, it is sure for PPROM and no further testing is needed. However, in 10 to 20% of cases, the diagnosis is doubtful, show extra tests or extra maneuvers are needed to confirm the diagnosis, and these include either amniosure or actium probe. Now, what is the amniosure and actium probe? These are biochemical assay in the vaginal fluid. Amniosure involving detection of certain protein called placental alpha microglobulin 1. However, the actium probe involving detection of insulin-like growth factor binding protein 1. What is the matter when these tests are positive? Positive support diagnosis of PROM. Can we use this test simply in isolation from the clinical finding? No. It should be used in conjunction with the clinical finding. What is the matter if these tests are negative? Negative means B-PROM is unlikely. But we should ask the woman to return for checkup and the subsequent visits for any new finding. What is the matter if the patient is in established labor? If the patient is in established labor, don't perform these diagnostic tests. Now, traditionally, we use the nitrazine paper tests that depend on the change of the vaginal fluid from normal acidic vaginal fluid 3.5 to 4.5 to the alkaline media of the amniotic fluid, and this test is associated with false positive result 1 to 17% due to urine, blood, semen, or trichomonas vaginalis. Or Fern test, which depend on the seeing of arborized sodium chloride crystals under the microscopy when the amniotic fluid or dried amniotic fluid is examined under microscopy, or Nile blue sulfate test, which depend on the detection of fetal fat cells from the amniotic fluid, or amniosense, which is a bad change its color. It is indicator for the amniotic fluid leakage. These tests was traditionally considered for diagnosis of B-PROM, but now not recommended according to the Royal College guidelines. What is about ultrasound? Ultrasound rule and Lycor volume support the diagnosis of B-PROM is unclear. Amniotic fluid dye installation under ultrasound guidance is then tampon test using dye either indigo carmine or sodium fluorescein. These maneuvers increase the incidence of infection, increase the risk of rupture of PROM if the patient is not rupture of membrane if the patient is not PROM, and may cause fetal trauma, so these tests are not recommended. So the recommended in diagnosis of PROM is 1. History suggested from sudden gush of watery fluid for vagina, confirmed by sterile speculum examination when we see pooling of the vagina with amniotic fluid or amniotic fluid coming from the cervix. If there is doubt about diagnosis, we should use special tests, either amniosure or actium probe. However, nitrazine paper test, Fern test, amniosense, and the Nile blue sulfate tests are not recommended. Ultrasound or amniotic fluid dye installation under ultrasound guided are not recommended. Now, what is about the management of pre-labor rupture of membrane? We should distinguish between two main groups. The first is PROM with chorioamnitis. Second is PROM without chorioamnitis. Management of PROM with chorioamnitis. Chorioamnitis equal termination of pregnancy irrespective of the gestational age. It is infection. So it should be done under umbrella of broad spectrum antibiotics. Antibiotics, can we modify them? Yes. Antibiotics are modified according to results of culture and sensitivity. What is the source of sample for culture and sensitivity? Blood and urine sample, main source. Or placental swab from corneo-amnion interface after delivery. What is about the neonate? Neonate is suspected to be infected, so it should receive appropriate antibiotic in proper doses. Management of prelabor rupture of membrane without chorioamnitis. First of all, we should confirm the gestational age. If it is term from gestational age more than or equal 37 weeks of gestation, we should give GPS prophylaxis when indicated. Then, wait for 24 hours for spontaneous onset of labor. If no spontaneous onset of labor for fear of infection, we should start the induction of labor with oxytocin, for example. If this is failed or there is other obstetric indication, we should do cesarean section. On the extreme pre-viable brom, less than 24 of gestation, the main item of management is counseling. Then we should decide expectant management or termination after explanation the pros and the cons of each pathway. Antibiotics and pre-viable brom are recommended for latency and prevention of infection. What is about management of pre-labor rupture of membrane without chorioamnitis in the period from age of fetal viability 24 weeks to 37 weeks of gestation? The patient should be examined for signs of infection, maternal or fetal compromise. Then, if the condition is uncomplicated, expectant management should be the rule, provided that patient not reaching maturity and no labor pain. However, if there is signs of infection, fetal or maternal compromise, fetus becomes mature, or there is a labor pain, delivery is the rule. Expectant management involves the following items. We should discuss inpatient versus outpatient management. What is the advice given to the patient, how the patient can be observed, and what is the drugs to be given. Inpatient versus outpatient. The Royal College of Obstetrician and Gynecologists suggests that decision should be individualized based on past obstetric history, if the patient have PROM in the previous pregnancy or not, a preterm labor on previous pregnancy or not, distance from home to hospital, markers of delivery latency, and home support. When we decide to manage the patient at home, we should take into consideration avoid intercourse, temperature every 4 to 8 hours, report CRP and white blood cell count every 3 days, hospital visits weekly if there is any complaint. What is about inpatient? Royal College suggests that inpatient is essential if delivery is imminent. However, the American College suggests hospitalization of all cases, and they have favorable reasons. They said that latency is common short period. 2, infection may be present suddenly without warning. 3, umbilical cord compression is a common finding, cannot be predicted. Advice, rest. Rest in bed or no, this is controversial. Vaginal examination only if patient is in labor under complete aseptic condition to exclude cord prolapse, and assess degree of cervical dilatation and effacement. What is about observation? This table shows different observations, either maternal or fetal, and suggested frequency that may increase or decrease individualized. But we should emphasize on normal maternal observation doesn't exclude intrauterine infection. So, if the patient have normal maternal finding, pulse good, temperature good, this doesn't mean that there is no infection. So, should we do vaginal swab to diagnose? The same. Vaginal swab culture produce high false positive due to this area of contamination. We do observation for maternal and fetus. The main concern is chorioamnitis. Chorioamnitis, it is easy to be diagnosed. In the practical life, we postulate different measures, but we should not have a cut-off value for each of them. So Center of Disease Control and Royal College of Obstetrician proposed a simple criteria for diagnosis of chorioamnitis. Fever is the cornerstone. Fever is the cornerstone. So fever plus 2 or more than of the following. 2 clinical finding, tachycardia, either maternal tachycardia more than 100 beat per minute or fetal tachycardia more than 160 beat per minute. 2 local finding, tender uterus, full smelling discharge. 2 lab finding, leukocytosis, CRP positive. This is in absence of other sites of infection. Then for diagnosis for chorioamnitis, first, patient should have a fever more than 38 degrees centigrade plus 2 or more of the following: maternal tachycardia, fetal tachycardia, tender uterus, full smelling discharge, leukocytosis more than 15,000, because leukocytosis up to 11 to 12,000 may be considered normal during pregnancy, or CRP positive in absence of other site of infection to explain these maneuvers or this finding. What is the CRP? In the clinical practice, we ask for do CRP, do CRP, do CRP. What is the CRP? CRP, it is a substance produced by the liver in response to infection or inflammation. It is used to diagnose and to follow. However, normally may be elevated in some conditions without actual infection. Mild to moderate elevation may be seen in cases of obesity, smoking, diabetes mellitus. It is more elevated in female than male. Certain drugs may lower the level of CRP. It may decrease with statins, may decrease with use of corticosteroids. We emphasize on this to interpret the CRP in conjunction with this finding. We should ask the patient about this finding. Some guidelines recommend doing culture as majority of amniotic fluid culture, as majority of cases are subclinical. Other postulated that amniotic fluid level less than 20 milligram per deciliter are diagnostic for chorioamnitis. Less than 20 milligram per deciliter of glucose in amniotic fluid. Others say that a rapid test is the interleukin 6 and the amniotic fluid. It is most sensitive and specific markers for amniotic fluid infection. But these are used for research till now. What is about the fetal observation? We should observe the patient for main items: fetal well-being and fetal maturity. Fetal maturity helps to decide the protocol of treatment. But what is about fetal well-being? As regard non-stress test and the fetal biophysical profile may be normal in cases of presence of chorioamnitis, presence of infection, even severe infection. How? Because it doesn't affect placental perfusion and the fetal oxygenation, and these tests depend mainly on placental perfusion or elevate placental perfusion and the fetal oxygenation. What is the optimum methods for monitoring of the fetus to predict the fetal outcome? Unknown, unclear, not yet determined. Now about the drugs. First, prophylactic antibiotic. A case of bronch, come to the emergency room. First, give antibiotic. What is the antibiotic? Royal College of Obstetrician and Gynecologists recommend using of erythromycin 2050 milligram oral every 6 hours for 10 days, or until labor established, whichever is sooner. Why we give prophylactic or latency antibiotic? First, prolong latency. Allow time to give corticosteroid. 2, reduce chorioamnitis. 3, improve neonatal outcome. When we reduce chorioamnitis and prolong pregnancy to allow time for giving corticosteroids, the end result is improving neonatal outcome. Unfortunately, erythromycin is unavailable in our country and majority of government and countries. So, Parkland protocol, it is one of the most easy protocols to be practiced. On myself, I use this protocol on the private practice. We give azithromycin 1 gram orally upon admission. Then give ampicillin 2 grams intravenous every 6 hours for 2 days. Then amoxicillin 500 milligram orally 3 times daily for 5 days. So in the Parkland protocol, we use antibiotics for 7 days. Erythromycin, as a guide of Royal College guidelines, azithromycin, ampicillin, amoxicillin, as given by Parkland protocol. Now, what should not be given, must not be given? Co-amoxiclav, which is a combination of amoxicillin and glavulinic acid, should not be used at all. Why? They should not be used because they increase the risk of necrotizing enterocolitis. Antenatal corticosteroids. The first question, why we give antenatal corticosteroids? Antenatal corticosteroids increase number and activity of pneumocyte type 2 of the fetal lung. Pneumocyte type 2 responsible for formation and release of surfactant. Also, corticosteroids increase production and the concentration of certain types of surfactant, mainly dipalmethyl phosphatidyl acetylcholine. What its value? What is the value of this surfactant? It decreases surface tension of the alveoli, allowing their expansion. يبقى دي الفاليو بتاعتها. طب دي فاليو فين؟ In the preterm. What is about the rule in near term or term? Some say that it activates the sodium-potassium channels, allowing clearing of the airway from fluid. Timing. The recommended timing is between 24 and 34 weeks of gestation, should be considered from 34 to 36 weeks of gestation. And recent guidelines suggest it can be used. This is out of our scope in this lecture, but the guidelines recommended its use before elective cesarean section up to 39 weeks of gestation. What is about doses? We use either betamethasone 2 doses, 12 milligram, 24 hours apart by intramuscular injection, or dexamethasone 6 milligram dose, 12 hours apart for 4 doses. One of the most important questions, prednisolone, hydrocortisone, can we use them for induction of lung maturity? To answer this question, we should explain the following. Corticosteroids should pass the placenta and reach the fetal lung to induce its effect. Prednisolone and the hydrocortisone are inactivated by 11-beta hydroxysteroid dehydrogenase enzyme present in the placenta. So, minimum amount will reach to the fetal lung, so their effect is nil in cases of prednisolone that is converted to prednisone. However, in hydrocortisone, it reaches to the fetal lung with very minimal amount. So, some authors recommend may be used, but the effect is not expected to be high. Maximum benefit of antenatal corticosteroids is achieved 24 hours after the first dose and up to 7 days after completion of the course. So, even if labor starts, we should start the dexamethasone or betamethasone course. Is it single course or multiple course? Single course is recommended. However, rescue course may be single rescue course may be administered if gestational age is still under the 34 weeks, delivery becomes imminent, some says within 48 hours and the other says within 7 days, and more than 7 days elapsed since the last course of corticosteroids. However, some guidelines say that this effect may be extended or recommended if more than 14 days elapsed since the last course of corticosteroids. Now, antenatal corticosteroids, if it is benefit only or benefit and risks? Yes. Benefits include decreased neonatal respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, neonatal mortality, and neonatal intensive care unit admission. What is about risks? Short term, including hypoglycemia in late preterm, transient increase of white blood cell count. Long term, increased risk of mental behavior and neurocognitive disorders. Not increasing risk of neonatal sepsis or chorioamnitis, but we should use them in caution with the patient with chorioamnitis. What is about patient with diabetes? Can be used with monitor blood glucose at its cause transient elevation of blood glucose level. Start within 24 hours, may return to normal within 3 to 7 days. What is about the use of antenatal corticosteroids in multiple pregnancy used with the same dosage and frequencies as singleton pregnancy? What is about magnesium sulfate? We know that magnesium sulfate is used for cases of severe preeclampsia, but we use magnesium sulfate for a neuroprotection. What is the action? First indication, used in cases of established preterm labor or when preterm labor is considered or planned to occur within 24 hours. Action. Magnesium sulfate protects the fetal brain by reducing the exostotic injury, inflammation, and oxidative stress. Also, it blocks the N-methyl D-aspartate receptor and stabilizes the membrane potential, فبيقلل الممبرين potential, يقلل excitation of the neuro cells in the brain. Timing. It should be offered between 24 and 30 weeks of gestation, but may be considered up to 34 weeks of gestation. In cases of Borom, it is not recommended before 24 weeks of gestation, but in cases of preterm labor, it can be discussed between 34 and 24 weeks of gestation. Dosage. It can be given in the same way as that in severe preeclampsia and eclampsia. في bolus dose 4 grams intravenous over 15 minutes, then 1 gram per hour for 24 hours or until birth, which come first, and should monitor the mother for presence of knee jerk, urine output more than 25 milliliter per hour in the last 4 hours, and respiratory rate, yes, not less than 12 per minute. If we use magnesium sulfate for 24 hours or more, the unit must be examined for serum calcium, magnesium, and skeletal adverse effects. What is about tocolytics? Old speaking, traditionally, we say that short-term tocolysis for giving corticosteroids, this may be considered in cases of preterm labor, but in cases of prelabor rupture of membrane, tocolysis in patient with B-prom is not recommended at all. What is about delivery? Timing, more than or equal completed 37 weeks of gestation if no contraindications to expected management. Mode of delivery, either vaginal delivery, which is the rule unless there is contraindication, or cesarean section for obstetric indication. So when we decide the vaginal delivery route, misoprostol and oxytocin are similarly effective in cervical ripening. Prostaglandin E2 insert can be used without risk of infection. With no risk of infection, or mechanical methods of cervical ripening are contraindicated اللي هي زي اللامين رياتنت وزي الفوليس كاستر ما نستخدمهمش في الحالة دي. What is about the fetal monitoring? Don't do CTG وintermittent auscultation. Avoid fetal scalp electrode, fetal blood sampling before 34 weeks of gestation. Baby should be placed at or below the level of the placenta. Delay the cord clamping for 60 seconds when mother and the baby are stable if no contraindication. Intrapartum GPS prophylaxis. لو اتكلمنا على الانترابارتم GPS prophylaxis, generally, what is the value? Value of intrapartum GPS prophylaxis is to decrease the risk of neonatal GPS infection, either early onset or late onset, and decrease the incidence of maternal infection. Generally, in cases of B-prom, all women with B-prom with established labor should receive GPS prophylaxis except those GPS negative screen. Generally, what are the indications of intrapartum antibiotic prophylaxis for general? First, all women should receive GPS screening through rectovaginal swab between 35 and 37 weeks of gestation. These patients may be either GPS positive, GPS negative. GPS positive should receive GPS prophylaxis. Alone, no. Other indications include GPS bacteriuria during current pregnancy, or history of GPS infected neonate in the previous pregnancy, or unknown GPS states. The patient had not received the screening between 35 and 37 weeks for GPS, but the patient had a risk factor including intrapartum fever, preterm labor, or prolonged prom. What is the prolonged prom? More than 18 hours passes since last rupture of membrane till onset of labor. What to give? If no penicillin allergy, we give penicillin G. The initial dose 5 million unit intravenous loading dose, then maintenance dose 2.5 million unit intravenous every 4 hours until delivery, ampicillin 2 gram intravenous loading dose, then 1 gram intravenous every 4 hours until delivery. What is the matter if there is penicillin allergy? No anaphylactic reaction, cefazone 2 grams every 8 hours until delivery. Anaphylactic reaction, clindamycin 900 milligram intravenous every 8 hours until delivery. Vancomycin 1 gram intravenous every 12 hours until delivery. Timing of GBS prophylaxis to be effective should be received at least 4 hours before delivery. Now, what is about the recommended drugs at different gestational age prom? Prom between 24 and 37 weeks of gestation should receive latency antibiotic, GBS prophylaxis, antenatal corticosteroids, magnesium sulfate for fetal neuroprotection. However, tocolytics are contraindicated. GBS pre-viable less than 24 weeks of gestation, receive latency antibiotic, no rule of GBS prophylaxis, antenatal corticosteroids, magnesium sulfate for neuroprotection or tocolytics. What about the non-recommended treatment options? Amnio infusion not recommended, tissue sealant, fibrin glue, and gelatin sponge are not recommended. Specific cases of prelabor rupture of membrane. First, herpes simplex virus infection. As we know, herpes simplex virus infection caused by herpes simplex virus type 1 and type 2. There are two main types, primary herpes simplex or de novo. The rate of vertical transmission is 30 to 50%. So the expectant management due to this high vertical transmission is controversial. Some authors with and some authors against, and the herpes simplex virus therapy is recommended. However, recurrent attacks, risk of vertical transmission is 3%, so expectant management is recommended. Herpes simplex virus therapy is recommended. Caesarean section recommended only if there is active disease or prodromal symptoms are present at the time of delivery. HIV, human immunodeficiency virus infection. Management, optimum obstetric care are clear. Individualized treatment based on gestational age, viral load, duration since patient is antiretroviral therapy. Follow-up, standard HIV guidelines by multidisciplinary team. We should know this point, duration since patient is antiretroviral therapy. So the vertical transmission in cases of HIV is not correlated with the duration of rupture of membrane, but it is correlated with the viral load or duration of antiretroviral therapy prior to delivery. Brom with cervical circulation. If it occurs before 23 weeks of gestation, pre-viable, immediate removal of the circulation to decrease risk of infection. If occur between 23 and 34 weeks of gestation, delayed removal to allow a course of corticosteroids. If it occurs at term, as soon as possible to decrease risk of infection. In all cases, we should send the cervical suture for culture. What is about prophylaxis of Brom? This is a simplified image. We need to close the tab. This table shows the preventive strategy and the level of evidence. First, smoking cessation, high level, adequate nutrition, moderate level of recommendation. Antenatal care and screening, regular prenatal visits, screening for infection, high to moderate, antibiotic prophylaxis for bacterial vaginosis with GBS, cervical insufficiency, either cervical circulage, progesterone supplementation, management of polyhydramnios, avoidance of trauma, monitoring and education, close monitoring of high-risk pregnancies, education for the mother for signs of BPROM. Take-home message. What should Einstein say? Pre-labor rupture of membrane means rupture of membrane before onset of labor, regardless of the gestational age. Preterm pre-labor rupture of membrane is a single most known cause of preterm labor. Term prom is usually a reflection of normal physiology. However, P-prom is a reflection of pathological process usually triggered by infection. Accurate diagnosis of rupture of membrane is based on history, sterile speculum examination alone. Additional tests, for example, amniosure or can be used when there is doubt about diagnosis. A digital vaginal examination in B-prom should be avoided unless advanced labor is impending. Management guidelines for B-prom should be strictly followed to minimize maternal and fetal complications. Conservative is the rule in B-prom as long as there are no complications. Conservative management includes hospitalization or home management, rest, minimize PV examination, drugs. Intrapartum GBS prophylaxis is essential for prevention of GBS-related morbidity. Lower segment cesarean section should be done only for obstetric indications in cases of pre-labor rupture of membrane. Prevention of PROM can be achieved by controlling of modifiable risk factors. Now, summarization of this lecture. Pre-labor rupture of membrane to be diagnosed from history, suggestive. Sudden gush of watery fluid per vagina is a suggestive for pre-labor rupture of membrane. When we suggest pre-labor rupture of membrane, we should confirm by sterile speculum examination. If sterile speculum examination is doubtful, we should use the accessory tests, for example, amniosure. Management of rupture of membrane, pre-labor rupture of membrane depend on the gestational age. In-term rupture of membrane after completed 37 weeks of gestation, we start with GBS prophylaxis when indicated. Wait for 24 hours for spontaneous onset of labor. If no spontaneous onset of labor, start with induction of labor with oxytocin. If this